Welcome back, everyone. We're on our second session of neuro-oncology, and the first talk we have now is the good Professor Kate Drummond, who's going to be talking about frameless stereotactic brain biopsies and how she does it.
Well, actually, I'm presenting this for Professor Yigal Shashan, who hopefully will join us online for the next talk. So it's how Professor Shashan does it. It's his slides, but I'm going to add some additional overlay to that. And although this might seem like a very basic topic, going through the steps of hearing how someone else does it is often a really good way to learn, particularly for the neurosurgical trainees, of what might seem like a very straightforward procedure, but certainly can get you into a lot of trouble. So the techniques for brain biopsy, of course, you can do a freehand biopsy or various types of stereotactic or image-guided brain biopsy, from frame-based to neuronavigation guided to robotic guided to intraoperative imaging guided, which could be ultrasound or intraoperative MRI or CT. I think really the freehand brain biopsy, except in the most superficial of lesions, is probably really not recommended, and we would always use some sort of image guidance to undertake a biopsy. So the frame-based is certainly how I learnt to do biopsies. That was all that was available when I was a young neurosurgeon, and of course is still quite common for the world of functional neurosurgery to use a frame. It has some advantages, the main advantage being it's extremely accurate. And that, I guess, is that why it persists. The disadvantages, of course, are positioning the patient in the frame. Getting that right has a lot of nuance. It can seem as though there's no direct correlation or understanding with the operative plan. They say poor patient acceptance, but when this was all we had, patients accepted it very well. We'd put the frame on with them awake, sitting in a chair and some local anaesthetic. But now that we have other options, that seems to become less acceptable, including for the surgeon. And it's quite cumbersome, particularly those of you young neurosurgeons probably don't remember inputting all the values, doing the mathematics and coming up with an XYZ coordinate that you weren't quite sure whether it was really correct until you started to set the frame and pass the needle. But still, it's certainly one option that persists. And for brainstem biopsies, where I'm doing a long pass from a frontal burr hole into the midbrain, I will often still use a frame because it's so accurate. The robotic biopsies, of course, I'm going to mention briefly and have become very popular in terms of that you basically set the robot with the entry point and the coordinates and drill the hole, and the robot does the rest for you. These, of course, seem like a great idea, but they're extremely expensive, and the question of what they add to a well-planned human-performed biopsy, whether it be a large, like the Rosa robot here, a large floor-mounted robot, or perhaps a smaller either patient or bed-mounted robot for doing these. It's difficult to know what the advantages really will be. But I'm sure that we'll see more of this from the better equipped units. I don't think Melbourne is going to have a robot to do biopsies for quite some time. You can use intraoperative imaging. Interestingly, we have an intraoperative MRI, but we don't use it to do biopsies because the frameless biopsies are so much more straightforward and easy to do. But you certainly, this is the Polestar MRI, which is a portable MRI, but you can certainly use any intraoperative MRI or ultrasound to guide your biopsy. But I think what most of us use, and I'm just wondering, in Vietnam for a biopsy, you would use a frameless biopsy most of the time? Frameless, freehand with navigation. Okay, yep. So this is we would use navigation either with or without a guide. Certainly freehand can work, just lining up your biopsy needle with the trajectory. That's certainly possible. But what are the important components of doing the biopsy that way? So you need a navigation system, and we all understand this. Some sort of workstation, some sort of tracking, whether it be infrared or electromagnetic, and some way to localize the patient's head in space. It can be the optical tracking technology gives you a real-time display of where you're going for the biopsy, to locate your tool, to orientate yourself in the anatomy, and for guidance for passage of the needle. It gives you an idea of relationship to surrounding structures. But you can, of course, also use electromagnetic tracking technology. The optical base is the most common, but it requires the head to be fixed in a Mayfield headrest, but it's very robust and very accurate. We also have an electromagnetic-based system. We use that less for biopsies and more for catheter placement for VP shunt. I think with the head able to move, it's probably less robust and less accurate. So we would not use that so much for biopsies. Registration is either with fiducials or surface matching, which are basically patient anatomical landmarks that you either create by applying fiducials, or you use the patient's natural landmarks. And you need some version of a digitizer or a camera to record those landmarks and the patient's head fixed so that you can refer to some sort of reference point. So the registration, either with fiducials or anatomically, we would tend to use mostly facial recognition matching with the Z-Touch Pros, the laser probe, bouncing the laser off the patient's facial features, but certainly using fiducials, which are stuck on before the MRI scan, can be very, very useful as well, and possibly more accurate if you're in a more featureless position, perhaps particularly posteriorly. Fiducials need to be placed in such a way that they are useful, so they need to be over less mobile skin. So areas where the skin is less mobile rather than more mobile. They need to be not all in a straight line around the meridian, and they need to be concentrated particularly over the site of the lesion. But you can use facial landmarks as well. The MRI, most people would use a T1 weighted with contrast MRI scan, but if you're looking at, for instance, a low-grade glioma, a flare may also be useful. The big trick that we've had with using certain MRIs is that they cut off the patient's nose on the MRI scan, and then, of course, you can't use it for facial recognition. That's very problematic, and it has to go from the very top of the head to the foramen magnum, 1 millimetre slice thickness. But you can use CT, and CT is very useful for this. So if MRI is not so available, then using a CT scan is very appropriate for this operation. You can get, of course, very fancy and register with all sorts of other imaging. So you could use PET scanning or what Matt was talking about, which is integration of functional imaging or tractography. But none of this is necessary for the biopsy, and usually passing the needle through a tract just divides them, and it's not a problem that you actually need to avoid them. So once you've registered, you go into the preoperative planning phase. And so that's really about choosing a trajectory. And choosing a trajectory is basically about the anatomy of the lesion. And in something like this, is very simple. The trajectory is a straight line from the surface of the skull into the lesion. Of course, once you start being in the posterior fossa with a more dense region of eloquent anatomy, or perhaps something like this, the pineal region, and I'm not quite sure what that trajectory is there. I would not be choosing that trajectory, but I think it's what's the word? It's imposed over the image, but it's probably actually coming from much higher up. But choosing the trajectory is what you can do with your planning software, and that gives you the ability then to define a surgical plan with an entry point, a target point, and a trajectory. Once you've done that, that then sets you up for the surgery. Everything is then very straightforward. These are the sorts of medications that IGAL uses. We would also not use prophylactic anti-epileptic drugs. I wouldn't give steroids except for perhaps a dose as an antiemetic dose. So we might give 8 milligrams of dexamethasone, but not for brain swelling. And they use 5-ALA prior to doing the biopsy, because if you take the specimen out and put it under blue light, you can be sure that you have tumour. That's very expensive, at about $3,500 Australian dollars for a vial of 5-ALA. So we would not do that, but that's what they do at Hadassah. The biopsy needle, as you know, is this side cutting needle, and you need to understand your system well to calculate the depth of the needle. Every system has a slightly different lead in, and so you need to know what that is to calculate the depth of your needle to your appropriate target depth, and then use the depth stopper, as you can see it here. IGAL obviously uses a very small 2 to 4 millimeter drill bit to make just a tiny hole to do either you can use mechanical, electrical or air powered and small drill bits. I actually don't do this. This is something that we disagree with. I drill a formal burr hole. So a slightly longer incision, not just a stab incision, and I drill a formal burr hole so that I can change my trajectory slightly partway through if I want to. But this is the way that he does it. And let's see. So unfortunately, I'm sorry guys, this is not a Brainlab system, so we'll have to blame IGAL for that. But these are the instruments being ready. The patient positioned for a lesion in the temporal lobe, and the operating room setup. The registration process, obviously using a combination here of fiducials and anatomical landmarks. With a navigated probe with optical tracking, and the patient obviously set up in pins with the reference frame. So then deciding on the entry point, which they're doing freehand. Deciding on preparing the entry point. So this is where I would make about a 3 centimetre incision. They're just going to make a stab incision. So you can see they're the manual drill, but I would use an air-powered drill, but that is irrelevant. And then the system to set up for guiding of their needle and their drill, which they set up in advance. So this is a freehand lining up of the trajectory along to the entry point, and then setting a cannula down which both the drill and the needle will go. I use a Varia guide, which you set up by setting the 3 joints based on the calculations of the planning station using the Brainlab, but you can use a freehand or a calculated technique. So IGAL's setting that up there. You can see it's navigated with a cable. with the drill, with a depth stop. What I really like to use here is a navigated needle that has the fiducial markers on it, so you can actually see where the tip of the needle is passing on your station as you go. But again, if you've set this up properly, that's not necessary, because you should be able to land exactly where your target is if you've set your brain lab up or set your navigation up properly. That's a nice core. So I guess I usually try and decide in advance how many cores I'm going to take. In general, I would take at the target point, one at each point of the compass. And then I would decide whether to advance or pull out by 5 millimeters or so from the target. I generally advance because I often find that, I don't know why, but often I find that I'm a little short of the target in the way that it gets set up. So you can do frozen section with a smear pathology, or this is what Igal was talking about. This is very nice if you can afford it, to give the 5 ALA. If you put your specimen under blue light, you can see very well to be ensured that you've got tumour any cellular tumour. It will work for, not just anything that enhances with contrast. The dreaded complication is blood through the needle. Of course, that's something that we all worry about. The most important thing is to not panic. Wait, wash, wait, wash, wait. Not let the blood accumulate within the brain. Allow it to come back up the needle. Venous bleeding will usually stop. If it's serious arterial bleeding, it can be very difficult. Igal considers injecting Surgiflow or flow cell. I don't know that I'd do that, but that's certainly one option. But I think the most important thing is if the bleeding has not significantly slowed after 15 or 20 minutes, then an immediate CT scan, or even considering a craniotomy straight away, depending on what the circumstances are. One of the biggest disasters that I've had was biopsying a low frontal and insular tumour that the patient got a devastating hemorrhage, lived a very long time with their low-grade tumour and a devastating deficit. Post-operatively, Igal says he does a CT scan within 2 hours. I don't like that. I think that is falsely reassuring, because the slow bleeding will happen over the next 12 to 24 hours. So I would do it. Tanya loves a 2-hour CT scan. It makes the nurses crazy because
I'm actually saying 1 minute, Kate.
Okay. Oh, all right. But she loves a 2-hour CT scan.
To the ward.
But it makes the nurses nuts because they have to take the patient down to the CT on the way to the ward. But I do mine the next day, and the patient can be discharged that day if there's no blood. The incidence of symptomatic bleeding is very low, about 1%, although it's quite common to see some bleeding, about up to 10% on the scan. This is Igal's series, and it's very interesting in that, this is my last slide, Tanya, so don't panic. Very interesting that, this is from his frame-based, and this is a classic example, of course, of collecting your own data, allowing you to make decisions on what's the best thing to do. Both in terms of mortality symptomatic bleeding, surgery for hematoma, neurological complications, and diagnostic yield, the outcome was better for frameless biopsy, I think, as it's developed over frame-based. That's over a very different time period. The difference in surgical anaesthetic advances between 1999 and 2002 may account for some of those differences. I mean, even the imaging that we're given is markedly different. So I don't think you can only put that down to the technique, but it shows that they're at least equivalent and if not better at this point. So I'll leave it at that, just reminding you of some other AASNS meetings, the Jaipur trauma meeting in March 2024, and of course in Taiwan, the AASNS meeting for our biannual Congress. Thanks very much.